Hello, everyone, and welcome to this brief session on an introduction to physiatry and our approach to low back pain. My name is Jason Friedrich, and I am a physician of physical medicine and rehabilitation, or PM&R, also known as physiatry. I'm an assistant professor of PM&R at the University of Colorado. I also serve as the associate fellowship director for pain medicine and am the course director for clinical musculoskeletal medicine for our residents. Clinically, I work at the Spine Center at University of Colorado Hospital, seeing primarily patients with spine-related disorders, but also those with sports injuries, joint problems, tendinopathies, and peripheral nerve injuries. I'm delighted to have the chance to tell you about PM&R and what we can offer patients with low back pain, as well as what we can offer physical therapy as a collaborator. The objectives for this session are listed here. My hope is that by the end of the session, you all can describe how PM&R fits into a value-based spine care system, be able to describe our management approach to low back pain in general, and see how well it aligns with physical therapy. When it comes to low back pain management, patients have a lot of choices, and unfortunately, where you live and who you see often determines what kind of treatment you are likely to receive. This care approach better resembles a game of Plinko than high-quality coordinated care. Perhaps even worse, many patients are seeing multiple types of care providers for their low back pain without much communication between these providers. When we remain siloed from each other, we risk creating more confusion and patient anxiety through each of us providing our own set of diagnoses and using our own terminology to describe things. Together, I think PM&R and PT can work together to do better. So before I talk more about low back pain, I want to take some time to explain what physiatry is. Physiatry, also known as physical medicine and rehabilitation, or shortened to PM&R, is a distinct medical specialty and has been so since the mid-1940s. In order to become a physiatrist, you need to complete 4 years of medical school, followed by a year of medical or surgical internship, then 3 years of PM&R specific residency training. The specialty came about to address the needs of soldiers surviving battle trauma or children surviving polio, but with significant functional loss that was not well addressed in the traditional specialties of medicine, orthopedics, or neurology. Historically, physiatrists served those patients with brain injury, spinal cord injury, amputations, polytrauma, strokes, and others. But in the late 1980s, more PM&R physicians began specializing in non-operative orthopedic care, sports medicine, and pain management. PM&R physicians are not surgeons, and we emphasize non-surgical care. We are distinguished from other medical specialties in that we are not an organ-specific specialty, such as gastroenterology or urology or neurology. Instead, we see patients who have experienced any type of function loss and focus our efforts on restoring function through accurate diagnosis and team-based management strategies, which almost always includes physical therapy. We are distinct from physical therapy in that we can prescribe medications, perform injections, order and interpret imaging similar to other medical specialties. But of course, in my opinion, physical therapists tend to be better than PM&R at manual evaluations, assessing for muscle imbalances, and of course, PTs have the ability to actually carry out a rehabilitation plan, which certainly cannot be done well by way of the occasional outpatient physician visit. Within residency and fellowship training, PM&R physicians engage in intensive training in the nervous and musculoskeletal systems. Unlike most other medical specialties, PM&R training emphasizes functional anatomy and biomechanics, musculoskeletal physical exam techniques, neurophysiology, and electrodiagnosis, and this includes training in both performance and interpretation of electromyography and nerve conduction studies, imaging interpretation, including X-rays, CT, MRI, and now more than ever, musculoskeletal ultrasound. Physiatrists also learn how to perform a variety of injections to help diagnosis and management of a wide range of musculoskeletal conditions, including X-ray guided spine injections and ultrasound guided joint, bursa, and tendon sheath injections, among others, to complement physical diagnosis and mechanical or exercise-based treatments. As I mentioned, we're also trained in how to prescribe medications, although try to use these sparingly when it comes to conditions like low back pain. So I see PM&R physicians as diagnosis experts, and as we discussed, we have many tools at our disposal to assist with diagnosis, including imaging, electrodiagnosis, and injections, in addition to physical exam. The training we get in musculoskeletal diagnosis is unique relative to other medical specialties. In virtually all situations except for an acute fracture or gross instability, our goal is to reassure patients and get them mobilizing again as soon as possible. We provide primary prevention through prescription and education on exercise in virtually all patients we see, secondary prevention of subsequent disability after initial injury through early diagnosis and often an early referral of PT, and tertiary prevention of cumulative chronic disability through multidisciplinary rehab. The PM&R physician should help anticipate care needs for the patient and the rehab team, such that the patient can anticipate what is likely to happen to them down the road, both on the short term and the long term. Is their back pain going to get progressively worse, be recurrent, wax and wane, or be cured? What kind of care needs are they likely to have? Finally, like a physical therapist, the PM&R physician should be working to foster patient self-efficacy, which is well known to be one of the best predictors of success and recovery. Self-efficacy is one's feeling that he or she can influence his or her own outcome and is fostered through motivational interviewing and promoting active over passive treatments, something all good PM&R physicians and physical therapists should be doing every day. Now, in our spine center, we have many specialties, including orthopedics, neurosurgery, anesthesia, PM&R, and pain psychology. We all use the same schedulers. To help reduce confusion, I tried to provide some language to our schedulers to help better define PM&R for our patients. I'll read it now. PM&R physicians are our diagnosis experts. They are specialists in non-operative spine care and sports medicine. Their role in our department is to provide a thorough evaluation and complete diagnosis, including identification of factors that may be contributing to your problem, such as altered posture or alignment or muscle weakness. Provide a treatment plan emphasizing physical rehabilitation and exercise, and sometimes also utilizing injections and/or pain psychology to facilitate your rehabilitation. Patients may ask, what does PM&R actually do? Our schedulers can say, your PM&R consult will include a comprehensive spine evaluation, including a detailed physical examination and review of imaging. Other diagnostic testing may be recommended, including nerve studies or diagnostic injections. Non-surgical treatment recommendations will be provided, as well as collaboration with a physical therapist and/or a spine surgeon if indicated. We strongly believe that the roles of PM&R and physical therapy need to be combined and complementary and not separate. Dr. Andy Haig, a spine physiatrist, has nicely created a soccer analogy. I agree with him that the role of PM&R, physical therapy, and in many cases pain psychology is to control the midfield and prevent the errant and unpredictable deep ball from the backfield to the goal-hungry forwards. We know that just living near more advanced imaging centers independently increases your risk of having spine surgery. Now, this is concerning. Controlling the midfield may better be able to improve patient health and healthcare value. So why does collaboration matter so much to low back pain? One reason is low back pain management is currently a failed state. Our healthcare system keeps devoting more money to low back pain care, yet we seem to be getting more low back pain related disability. So in other words, there's a great opportunity to do better. Secondly, patients hate confusion. Nowadays, Patients expect large systems just to not coordinate well. Care coordination is often as or more important to patient satisfaction than clinical outcomes, especially in patients with chronic pain. Care coordination requires communication between the rehab team, consistent messaging to patients, and an understanding of each other's role in order to be effective. Part of controlling the midfield is being able to provide consistent messaging to patients. This requires that a PM&R, doc, and physical therapist communicate with each other about what's going on and be able to identify barriers to improvement. So in the last few minutes, let's shift gears towards the PM&R framework for assessing low back pain. Similar to physical therapy, a good PM&R physician understands the generally favorable natural history of most musculoskeletal conditions and the body's capacity to heal and adapt if just given the chance. A good PM&R physician recognizes the difference between nociception, disability, and suffering, and the different treatment approaches required. A good PM&R physician is not afraid to take on multifactorial low back pain, which is good because it's almost always multifactorial. Our job is to find and address the factors and make sure that the diagnosis makes sense in the full clinical context and not just rely on imaging findings. So what can cause pain in the low back? We spent a lot of time talking about pain generators listed on the left there. But we need to remember that these are not the things that tend to predict disability or poor functional outcomes. Those things are listed on the right, listed as disability generators, also known as yellow flags of disability. This list really needs to be addressed with at least equal intensity as the pain generators on the left. As I mentioned, most low back pain is multifactorial, including the effects of functional instability from muscle imbalance or deconditioning, as well as abnormal posture, poor muscle recruitment, emotional stress, age-related changes including disc degeneration, arthritis, ligamentous hypertrophy, lack of confidence in one's body, the yellow flags I mentioned, and central sensitization of pain. When alignment or movement patterns deviate from the ideal, then abnormal wear on the tissues is more likely. Our brain can process these changes and sensations as normal or abnormal, depending on our psychological state and beliefs about pain. Physiatrists take seriously both physical and psychological factors involved in low back pain. For instance, similar to a physical therapist philosophy, we consider both segmental instability as well as muscle imbalance and neural processing problems. In terms of psychological factors, we know that about 30 to 40% of patients with chronic low back pain also have depression, and that there's a strong correlation with pain duration, severity, and disability. Patients' beliefs about pain are also important. Fear avoidance predicts disability and time off work better than pain levels, MRI findings, or the underlying diagnosis. Cognitive behavioral therapy can decrease fear avoidance beliefs and disabilities, even if pain levels do not diminish. Diagnosis is all about pattern recognition, and repetition matters. Here's a rough guide to some of the patterns we start with in patients with primarily axial low back pain, and the diagnoses and terms we commonly use. Certainly, the things we discussed regarding multifactorial low back pain still apply, even when a more specific diagnosis can also be made. Although more rare, the things listed on this slide also do happen from time to time, and history remains the best means for diagnosing these not to be missed conditions. which typically make up less than 5% of back pain presentations at the Spine Center. Now, what about patients presenting with more leg pain? We reserve the use of the term radiculopathy for when there is an objective dermatomal or myotomal deficit. If just pain in a dermatomal pattern, then call it radicular pain. If just tingling in a dermatomal pattern, then call it radiculitis. Between age 30 and 50, radiculopathy is usually from a disc herniation. Older than that, then it may be more from arthritic or age-related degenerative changes, such as joint hypertrophy and redundancy of ligaments and joint capsules, causing stenosis. We generally use the term chronic pain syndrome in situations where someone has persistent pain with significant secondary consequences. It's difficult for any single provider to be successful with these patients, and an interdisciplinary approach may be more effective. Though not universal within PM&R, I try to reserve the use of myofascial pain or chronic myofascial pain in situations where there's a cause that can be addressed, such as poor posture or muscle imbalance. In other words, myofascial pain is more of a symptom than a primary diagnosis, and I think a good PM&R physician, like any good physical therapist, should go looking deeper for the causative factors in order to be successful in these patients. So I will leave you with some comic relief. Please understand that you have an ally with PM&R, and that PM&R physicians want to collaborate with you and have great respect for physical therapy and the care that physical therapists provide. I believe that physical therapy and most PM&R physicians align philosophically, and that we just need to talk to each other more. So thank you for taking the time to listen, and I look forward to our upcoming session together.